On the 25th of September at 7, we will be joined by Dr. Michaela Beetge from the University of Pretoria, and she will be presenting the topic Empowering Patients and Students in Periodontics, the 2080 Rule and Effective Patient Education. Then I would just like to ask, tonight we are not going to accept any raised hands while we are busy with the lecture. If there's any questions, please type it in the Q&A box at the bottom, and at the end of the lecture, we will address them live. Now it's my great pleasure to introduce our speaker for tonight, Dr. Theesan Vedan. Dr. Vedan is an oral medicine and periodontal specialist. He's based at the University of the Western Cape in Cape Town. He completed his undergraduate training at the University of the Western Cape in 2012. In 2023 to 2024, he did his community service at the South African National Defence Force in Oudtshoorn. He, between 2014 to 2015, he was an emergency dentist at the University of the Western Cape, where he did screening, diagnosis, and managing of minor maxillofacial concerns. He was an associate lecturer and emergency dentist between 2014 to 2016 at the University of Witwatersrand. He did field epidemiology from 2016 to 2018, and he did that at the National Institute for Communicable Diseases, where he did field research, managing of infectious diseases, and public health management. And then also, during that time, he did his Masters of Public Health in Epidemiology at the University of Pretoria, and he also did a postgraduate diploma in from 2018 to last year, he was a registrar in the periodontal department at the University of the Western Cape. He got his degree last year as a specialist in periodontics, and he's currently working as an academic staff member at the University of the Western Cape. Dr. Vedan, we are all very looking forward to your lecture tonight. And it seems like we are still climbing, but I think you can start with tonight's lecture. I'll give the floor to you, Dr. Vedan.
Okay, thank you very much for that welcome, Dr. Stander. So tonight we'll be delving into a topic that has become increasingly relevant in everyday practice for us, peri-implantitis. And recently here at the university, we've actually dealt with a lot of peri-implantitis patients. We seem to be removing implants or treating, managing these complications more and more often. Dental implants have certainly revolutionized tooth replacement, but with them comes these unique challenges. Peri-implantitis is often silent at first, but by the time it makes its presence known, by the time the patient actually comes to us, we're talking about significant bone loss and then making the decision to remove the implant. So what we're going to do, the purpose of today's talk is to shed some light on peri-implant disease, specifically within the framework of the 2018 classification for periodontal and peri-implant diseases. So we want to know how to classify it. This is based on the World Workshop that was done quite some time ago now, so we don't refer it to it as a new classification anymore. And it lays out a comprehensive understanding of the conditions. We want to distinguish peri-implant health, mucositis, and peri-implantitis. And why is that even important? Why do we need to know these differences in our everyday clinical practice? This is because they provide us with clear diagnostic criteria, and it makes us easier for us as clinicians to assess and manage these conditions early. We're also guided by another set of guidelines, which is the European Federation of Periodontology, or the EFP S3 guidelines. So these guidelines are based on best available evidence. They develop these guidelines through rigorous systematic reviews by meta-analysis and expert consensus. And they ensure us that recommendations are not only scientifically sound, but are clinically practical. It's taking the guesswork out of peri-implant disease management. But why are these even important? You know, these guidelines, they published every few years, they're updated, but they offer us a roadmap at this stage for maintaining peri-implant health, diagnosing the diseases, and applying our evidence-based interventions. One key takeaway of the current guidelines, which we will be delving into during this lecture, is the importance of maintenance. Studies have shown that basically, if a patient skips their follow-ups, it's going to drastically increase the risk of implant disease. And while we're still piecing together the exact microbial and cytokine culprits, we know that regular monitoring and biofilm management are absolutely essential for long-term success in patients. While our implants are life-changing for patients, they're not the set it in and forget it solution that a lot of our patients think they are. Our long-term success is important, and it's based upon our vigilance in maintaining that peri-implant health. So let's dive into how these guidelines can help us to ensure that the future of our implants remains bright without any unwanted surprises. So this is a case that we saw recently, and this is becoming more and more prevalent. Just a reminder that all patients have consented to participate, and their images are being used for educational purposes. But what makes this issue such a big problem to deal with is because of its stealthy progression. Initially, you might have mild symptoms such as bleeding on probing, slight swelling in some areas, but really the bone loss, and studies have shown us, is far more destructive than what we see with periodontal disease around teeth. Once the osseointegration starts to degrade, getting back bone in those areas becomes incredibly challenging, and implant failure becomes a real risk. What's more even concerning is the variability in how patients present. One patient could lose millimeters of bone in a few months, while another may remain completely stable for years. This variability makes early detection absolutely crucial. So it's not just about the clinical signs, but we need to employ radiographic monitoring as well to catch those early signs of bone loss before it's too late. So peri-implantitis might be silent in its onset, but the consequences are anything but that. So it's time for us to enhance our preventative care and ensure that we have regular monitoring of it to ensure our implants remain in place. This is a video shared with me, courtesy of Professor Stavropoulos at Malmo University. And you can see this implant really wants to get going and get out of there. And
Dr. Vedan?
Yes.
Sorry, I don't see you sharing your screen with us.
Oh,
can you just check on your side?
Okay. Sorry, have we
No.
not been sharing this entire time?
No.
Okay, that's okay.
Thank you, Dr. Vedan. Awesome.
Okay. All right. Okay, so I just wanted to show everybody initially. So those EFP S3 guidelines, our talk is basically we're going to be focusing on that today, the S3 guidelines. And then we're going to be also looking at the classification of periodontal and peri-implant diseases and conditions. So we're going to link these two and talk about why it's relevant for us to utilize these guidelines in our everyday practice. And secondly, I just wanted to show us a picture of some of the types of patients we're seeing more frequently in our practice, and we're seeing them at the university as well. So we're looking at some of the factors that might have contributed to the solutions, and then what the EFP guidelines recommend we do in these type of situations. So this picture was kindly shared this video by Professor Stavropoulos at Malmo University. And we can see this implant wants to get out of there. It's had enough. And I'm very fortunate I'm going to be spending the next year with Professor Stavropoulos, who's one of the leading academic and clinical voices on peri-implantitis. I'll be spending the next year with him in Sweden. We also have to be wary of what gets touted as a miracle cure to treat peri-implantitis. We've go to these conferences, we've seen the flashy claims from different companies touting miracle products that might promise to regrow bone, to eradicate infection for your patients, reverse peri-implantitis. We can do this with a very quick spray or just a single laser session. The reality is far more complicated than this. And unfortunately, many of these treatment options lack substantial clinical backing. One thing that we need more information about is photodynamic therapy and certain locally administered antibiotics. And we'll touch on these a little bit later on when we go into the actual EFP guidelines. But there are many systematic reviews by Schwartz and Heitz-Meitfeld, etc., that have showed that these approaches are inconsistent in their results, or they provide very minimal additional benefit when compared to just standard mechanical debriding for your patient. Moreover, the use of lasers for treating peri-implantitis, it's become popular at the moment, but we still need to see consistent long-term success in improving peri-implant health outcomes. There's studies by Romanos in 2019, and they actually showed that lasers may be effective for more of the soft tissue management, but they do not guarantee sustainable bone regeneration or implant stability in the long term. So this part, we just wanted to just make sure our focus is on using evidence-based approaches, mechanical debridement, surgical interventions when needed, and emphasizing the importance of regular maintenance. Products that offer us this quick fix, they often bypass the complexity of peri-implantitis, and it leads us into going for selecting treatment options that don't address the underlying issues effectively. Now let's go back to that classification system. And we needed to have a more standardized system to discuss and diagnose these conditions. And we achieved this thanks to the 2017-2018 classification. So it's a toolkit. It helps us to communicate with each other more effectively. We can communicate with our specialists more effectively, and not only with just between us as colleagues, but also with our patients. And we're going to align that with today's evidence-based practices. So very simply, peri-implant health, that's our goal. We want no inflammation. We want very stable bone levels. Everyone's happy at the end of the day. Peri-implant mucositis, the early warning signs are here. There's inflammation, which is confined to the soft tissues around the implants. Think of it as having gingivitis for implants. Peri-implantitis, this is the bigger one. So there's inflammation plus bone loss around the implant. And here's where things get tricky. Unlike periodontitis, peri-implantitis lesions tend to be more circumferential and more aggressive. So they involve higher number of neutrophils and B cells, like the immune response really goes haywire. Then lastly, peri-implant hard and soft tissue deficiencies. So these are defects in the hard and soft tissues that can occur around natural teeth or implants. Why do we even care about this? Why is this important? Why is it important for us to diagnose these things? Well, peri-implant mucositis is treatable, and it's reversible with early intervention. We treat it as gingivitis, good oral hygiene, regular cleaning, professional maintenance. But peri-implantitis, that's when irreversible tissue damage sets in. Even if we control the inflammation, we can't fully restore the lost tissue. So diagnose early, treat early, and we're going to avoid a lot of headaches for ourselves and bone loss around the road. So it's very important for us to diagnose between these conditions, because then they're going to lead us down our various treatment pathways. We now have this common language and clear criteria, and it's time that we start implementing it every day. Now let's go into more of the nitty-gritty of it. We said that peri-implant health is the ideal, so there's no inflammation, stable crestal bone levels, which is important. And they've recently updated the definition so that there is a single bleeding spot can be an early red flag for these patients in peri-implant health. Peri-implant mucositis, this is an inflammatory condition, and there is generally no bone loss around these patients. So you're going to see the clinical signs of inflammation. You're going to see bleeding on probing spores, and it's bleeding upon gentle probing in those areas. You get swelling, redness, or even suppuration around those areas. So at this stage, it's reversible. And here, the biofilm accumulation is what's going to be contributing to the patient's mucositis. Smoking, there's other factors and treatment that the patient could be undergoing as well. Peri-implantitis, unlike the mucositis, this is going to progress. There's going to be bone loss with the inflammation. You're going to have bleeding on probing, increased pocket depth, suppuration, mucosal recession. There's radiographic bone loss. That's going to confirm the progressive nature of the disease. So often develops due to poor biofilm control. So a history of severe periodontitis can contribute to it, inadequate post-implant care. There's other factors that can also contribute to peri-implantitis, which is occlusal overload for keratinized tissue or submucosal cements. So we'll go through some of these definitions because we might have forgotten what keratinized tissue is. And then systemic factors as well, such as smoking or diabetes, it may exacerbate the condition. The jury is still out on how much and how much of an effect these conditions really have. But there's also the role of things like titanium particles, bone compression necrosis, biocorrosion. These are all new things that we're also looking at in terms of peri-implantitis. Now, hard and soft tissue deficiencies, this stems from bone loss or surgical complications, and these are defects that occur around our natural teeth or implants. The update that I mentioned earlier, that emphasizes that more than one bleeding point around the implant or profuse bleeding is going to indicate mucositis. So one bleeding point, we're still within peri-implantal. On the other hand, peri-implantitis involves bone loss, which is going to be more than 2 millimeters, and your pocket depth is going to be greater or equal to 6 millimeters. So now we've gone through the classification, and it just provides us now with clear diagnostic criteria that we'll be able to communicate more effectively amongst each other. So this is a patient. These are some of my cases that I've seen. Let's take a closer look. So this patient, we can see that there's some hard and soft tissue deficiencies. So typical presentation, edentulous patient, she had her teeth extracted quite early, quite common in Cape Town. And we can see the amount of bone resorption that's occurring here. We've lost vertical height, we've lost width, we've lost keratinized mucosa. Now this is part of the 2018 classification. Then there's various factors that can influence residual alveolar ridge, the ridge width and height after a tooth is removed. The first factor we encountered that influences the hard tissue deficiencies is the normal resorption and healing process after an extraction. So after a tooth is removed, we know that there's going to be a reduction of both height and width and the soft tissue. But this poses a challenge for us with implants, and this complicates our procedure. So that's why recognizing these factors, it really helps us when it comes to managing it. Other things that could occur that the classification mentions that could affect the peri-implant hard and soft tissue situations are things like medications, systemic diseases. So osteoporosis, we look out for diabetes as well. And those are going to affect our body's ability to regenerate bone in some areas and reduce our natural healing response. Then this patient's been wearing dentures and been wearing dentures for a long time, 20, 30 years. And this prosthesis pressure can exacerbate the condition because we know that mechanical force has been applied to that area and it's further reduced our bone volume, so quite severely. So when these multiple factors combine, the severity of the tissue deficiency is going to worsen. It complicates our implant treatment process. So now I've got to start thinking, this is not a simple case of just putting some implants there and sending the patient off. We've got to now address these issues to create a healthy peri-implant environment. Addressing these deficiencies early is going to make sure that my patient here is going to have successful long-term implant therapy. So let's park this case on for a bit, and I'll show you how we managed it. Another patient. So this is the third patient we've seen today. So we've seen the first patient who was the gentleman who came in with multiple failing implants. We remember, I think I'll go back to that picture because that's the part where we didn't have the PowerPoint up. But multiple failing implants, poor situation. The second patient was our peri-implant hard and soft tissue deficiencies. And here again, we can see the issue here. It's malpositioned implants, right? So here it could be also related to hard and soft tissue deficiencies at the initial stage. So after the teeth were extracted, implants were placed in, and this also forms part of the classification in terms of hard and soft tissue deficiencies. So patients who have experienced severe periodontal or peri-implant disease, very traumatic extractions, or have had thin buccal plates to begin with, these factors lead to more substantial alveolar ridge deficiencies. So you can include other complications here if the patient had endodontic infections or poor implant tooth positioning. That's going to contribute to the degradation of both hard and soft tissues. In addition, in the maxilla, we also going to have to think about the pneumatization of the sinus, where that's going to further complicate implant placement and lead to hard and soft tissue deficiencies as well. Now, how bad is this problem? Unfortunately, in South Africa, there's not a lot of data on the amount of peri-implant mucositis and peri-implantitis. If anyone's interested in doing a epidemiological prevalence study or incidence study, please, we'd like to see the data coming from our country. But Dirks in 2015 showed that peri-implantitis affects anywhere between 19 to 65%. So let's park that 19 to 65%. That's quite a big bracket of implant patients. And peri-implantitis, that as well, it ranged anywhere between 1 to 22%. So there's quite big ranges that we're dealing with. And that's because of differences, and we can see the issues when it comes to the definition of some of these conditions, how a peri-implantitis diagnosed in these different studies that they've done. And that's why it's important. We're seeing the importance of having a more standardized definition of these conditions. Other studies have shown peri-implantitis. The EFP mentioned that mucositis prevalence was around 43%. This means that we're talking about 1 in every 5th patient could lose 2 millimeters of radiographic bone. So we can see that implant treatment is not that straightforward. Rakic in 2017, they showed us that at patient level, our prevalence of peri-implantitis is 18.5%, and at implant level, it's 12.8%. So we can see these are quite high numbers and alarming. We're looking at close to 1 in 5 patients. So we need to think about how we're going to diagnose and manage our patients. So it's important for us to recognize the differences between teeth and implants, progression of the diseases. So let's start with the main difference between your teeth and implants is that your teeth are anchored by cementum, and we've got the PDL in place. And implants lack this, and they are in direct contact with the alveolar bone. The periodontal ligament in teeth, that's going to absorb your forces and then maintain stability, which implants replace with a more rigid bone interface. So if we look at the pictures there on the right and left, that shows us the histology in those areas. And if we look at the picture on the right there, we can see at the top, that's the inflammatory infiltrate. And between those 2 red lines is a protection there. So we're looking at a tooth, the gingiva tooth interface. And the connective tissue actually has a protective element there. So it's protecting the underlying bone from the inflammatory infiltrate. If we go to the picture on the left, showing us histology of a implant and mucosa. We can see above the red line inflammatory infiltrate, but just below that, that's direct apposition with the bone. So we can start understanding how these two conditions are quite different for each other, and therefore they need a different approach. So in terms of similarities between them, we know they both rely on hard and soft tissue to maintain health and function. But in the pathophysiology, our research has shown that there's parallels between implantitis and gingivitis and peri-implantitis and periodontitis, where both are driven by biofilms. But peri-implant tissue differs. And in peri-implant mucosa, you'll have a longer epithelial attachment. There's lack of the connective tissue fibers and reduced blood supply compared to the periodontal tissues. Whereas peri-implant mucositis is going to mirror gingivitis, so the inflammation is confined to the soft tissues. And like gingivitis, it is treatable with effective biofilm control. However, if we leave this untreated, we're going to have progression to implantitis. So in our classifications now and the guidelines, they've sort of stated that mucositis, when we see mucositis, we're going to have eventual progression to peri-implantitis, which will then lead to bone loss, much like untreated periodontitis. So the lesions in peri-implantitis, for those reasons, they're going to be much larger, more circumferential as well. And you're going to have higher levels of neutrophils and B cells. So there's going to be a more robust immune response than what we see in periodontitis. We can see there are similarities, but a lot of differences. And therefore, our approach to managing it needs its own considerations. Now, we spoke a little bit about the keratinized mucosa, and in that edentulous patient, we spoke about the lack of keratinized mucosa. But let's just go through some of the definitions again. So the keratinized mucosa, this is a band of keratinized tissue, and our guidelines. So if we look at the top area, it's got keratin in it, it's more protective, it's stronger tissue. And we need at least 2 millimeters. And this is for different reasons, because it's going to reduce brushing discomfort. You'll often find in patients who don't have enough keratinized mucosa, they brush that area, they have a lot of pain, they're unable to maintain that area, and then this leads to progression of the peri-implantitis or mucositis, because they can't clean, they can't keep it, there's more biofilm accumulating there, and we have progression. So when we have that 2 millimeters, there's going to be less plaque accumulation and reduce inflammation. And that will contribute to our long-term peri-implant health. If we have this adequate keratinized tissue, we're going to reduce the amount of recession, attachment loss, and early implant failure. It also minimizes the likelihood of developing peri-implantitis. And then on the other side, we see on the right-hand side here, soft tissue volume. So not only the amount of keratinized tissue, how thick is our volume as well. A volume more greater than 2 millimeters, these form part of the recommendations. This is going to enhance our pupillar scores and contribute to function and aesthetics. We're also going to reduce mucosal recession, and we're going to protect our implant. More significantly, research shows that we're going to have 5 times less crestal bone loss, which is vital for the long-term success of the implant. And if you have some time, please read the Thomas Linkevicius book on the zero bone loss concept, where he talks about the importance of soft tissue thickness. The peri-implant tissue that surrounds the osseointegrated implant, it's going to provide now, so both our thickness and our width, we're going to provide an important role in the stability of the implant. So the implant and the abutment is the hardware, but this soft tissue is the software. So we tend to spend a lot of time thinking which hardware we're going to use to improve our outcome. We need all of these design features and stuff, but we also need to make sure our software is intact as well. These tissues are going to provide our seal and support the overall health of the implant and ensure that we have a balanced biofilm around it. So there's limited evidence to say that a lack of keratinized tissue will directly lead to peri-implantitis, but we know that it's important in terms of the optimal oral health hygiene care routine for our patient. So this absence of the significant keratinized tissue is going to make this more difficult, which is going to lead to progression of our disease. So yeah, this basically shows us the same thing, but we go into more detail and we can see the vertical dimensions of this. We can see the soft tissue, the STH, that's a vertical dimension of the soft tissue, and it includes the sulcular epithelium, the junctional epithelium, and the supracrestal connective tissues. So just some components. We know that teeth have a longer STH, while proposing the short STH is less than 3 millimeters, and a tall STH is greater or equal to 3 millimeters. So that talks about the soft tissue height in those areas. We know that around implants, that tends to be about 1 to 1.5 millimeters. It needs to be higher than natural teeth. This is a critical insight because the soft tissue height, like the keratinized mucosa width, can also provide a significant role in both the aesthetic and functional outcomes of our implant treatment. So here, the key point is that the mucosal thickness is going to have a profound effect on the health and aesthetics of the patient. And then we need at least 2 millimeters of thickness. And anything thinner than that is less than 2 millimeters. So let's park these classifications because we're going to need this when we diagnosing our conditions and when we look at how our implants place, because these can lead to further propagation of some of those risk factors, and eventually it will affect our long-term implant health and the aesthetic stability of the peri-implant region. Another important factor is the peri-implant bone thickness. So this refers to the horizontal dimension of the bone that supports the osseointegrated implants. We need a minimum of 2 millimeters of peri-implant bone. So this measurement, it gives us a guideline to ensure the implant is properly supported and housed within the bone. When it's below that threshold, it's going to compromise the stability of the implant and increase the risk of our implant failure or bone loss over time. So we must look at the height at various apical coronal heights around the implant. It can even be completely absent in areas with a bone defect. So it's important for us to spot these things early, to look at fenestrations or dehiscence. So when we're looking at our implant site, we judge it in a complete apical coronal manner. So when we encounter these conditions, additional augmentation procedures are quite necessary. So we can then look at GBR procedures to maintain our volume. Okay, so risk factors. Let's look at the strong evidence first. So what risk factors are going to really affect our implant placement and thus at risk of developing these peri-implant issues? So chronic periodontitis. They have been shown to be at significantly higher risk of developing peri-implantitis. This is something we just can't overlook. Periodontitis causes alveolar bone loss, and that's going to affect both the volume and density of bone, and that's going to pose a challenge to our implant support. Then patients who have poor oral hygiene skills, patients who don't attend regular maintenance care after implant therapy. So these are accepted high risk or strong risk factors for peri-implantitis. And here we're going to emphasize regular follow-up for these patients. While we know that smoking and diabetes are often considered potential very strong risk factors for peri-implantitis, so when it comes with periodontitis, when it comes to peri-implantitis, the direct association is a bit more tricky. And this is something that we need to consider when formulating patient-specific risk assessments. So suggestions are that it is a risk factor, but we still awaiting further conclusive evidence. Now, when it comes to more limited evidence, things like the presence of submucosal cement in that area after restoration, keratinized mucosa, and even design and positioning of the implant. So we do understand that these are risk factors, but at this stage they haven't grouped it under strong evidence. So there's been studies by Kataguchi, and they spoke about things like the emergence angle of the implants that can affect the cleansability of and the risk of having peri-implant complications. Now, we have our patients in, we know there's various risk factors. How can we as clinicians make better decisions when looking at these patients? Are there any tools that are available? So this is a freely available tool. You can look at the article by Heights Mayfield, and the implant disease risk assessment was introduced in 2020. So it's useful. It shows you the risk factors involved before you start implant treatment for your patient. I also think it's a very helpful tool in terms of patient motivation. You can show the patient their potential risk in placing this implant, and then use the tool and update it while your patient is undergoing treatment. So they can better visualize the risk for their implant treatment. Here, what exactly is it? So there's 8 different parameters here. That shows us the risk of peri-implantitis. And we put it all into this diagram, and you will get an idea with the different vectors on the actual risk of the patient in terms of peri-implantitis. There's different areas. You get the green area, you get the yellow area, and the red area. So those are the different risk areas. So red will be high, green is low, and yellow will be moderate. Yeah, it's basically, there's a lot of questions. You enter all your patient information there, things like the history of periodontitis. They speak about, so you would look at the history of periodontitis through your radiographic exam, through your clinical exam with your patient. The bleeding on probing percentage, that's a critical clinical marker. So we look at the percentage, 10%, a score over 25% is going to be more of a high risk. So there's different percentages there, and you would input that onto your diagram. Other factors that are included in this diagram would be things like the pocket depths of the patient, more than or equal to 5 millimeters. This is going to show us an increased risk of peri-implant disease. And we also see things like bone loss in relation to age. That's going to help gauge its progression to periodontitis for your patient. And finally, the supportive periodontal therapy. That's going to be crucial to maintain our peri-implant health. So that's also a factor in terms of patients who are able to adhere to a regular recall system. So you want to have ideally less than 5 months between visits, have a low risk of peri-implant disease. And those who do not comply with maintenance therapy are at an increased risk. The guidelines subscribe to these different levels of prevention for peri-implant disease, and they highlight the timing of interventions across the stages of implant therapy, from pre-implant placement to after disease onset. So there's different stages, and we start off firstly with the primordial prevention. So this is reducing all of our risk factors before we actually go in and place our implants. So we want to prevent issues such as smoking, poor oral hygiene, that may later compromise implant health. Secondly, primary prevention. So this is after we've now placed our implant. The goal here is to prevent the onset of disease, such as peri-implant mucositis, through regular monitoring and educating our patient on maintaining optimal oral health. The step here is crucial in maintaining healthy peri-implant tissues. Then we go on to secondary prevention. This level focuses on preventing the disease recurrence after you've now treated the patient. For instance, after managing peri-implant mucositis, it's vital to follow up with routine care to prevent progression to peri-implantitis. And then lastly, we have tertiary prevention, which is aimed at preventing complications in patients with advanced peri-implant diseases like peri-implantitis. So at this stage, we are focused on managing this disease to limit further damage, which protects the implant and maintains functional and aesthetic outcome. So it's quite a logical flow of treatment, with primordial being more the preventative factors, with primary prevention being after you place the implant and how we're going to prevent the disease from starting. Secondary prevention is when you're going to now treat it and you're preventing it from recurring. And tertiary is when we're going to prevent the complications with advanced disease. Basically, it shows us more or less of the same. We have a structured framework that the EFP guidelines shows, and it shows us a framework for disease prevention and therapy at various stages of therapy. It emphasizes both preventive and therapeutic interventions. So when your patients are awaiting implant, you're going to go more towards primordial prevention. For patients receiving it, we obviously going to go, we want to maintain healthy peri-implant tissues during the implant or prosthesis placement. And we're going to emphasize oral hygiene and professional care. And then we're going to go into the maintenance phase. And then lastly, when we're dealing with peri-implantitis, we're going to shift then our thinking towards therapeutic interventions, such as surgical steps. The key takeaway here is that the early identification and treatment, along with regular evaluation, are quite important to maintain implant health and prevent further complications. Firstly, our steps in the primordial interventions. This happens before our implant placement. We're going to use our tools such as IDRA. We're going to identify those modifiable risk factors, such as smoking, diabetes, poor oral hygiene. So we're going to ensure the patient's periodontal health is stable, especially if they have a history of gingivitis or periodontitis. Our supportive periodontal care should be implemented and maintained. Secondly, when it comes to the three-dimensional positioning of the implant, in our primordial interventions, we're going to ensure that there's sufficient buccal and lingual bone tissue thickness to maintain our primary stability. We also need to maintain an appropriate mesiodistal dimension as well to allow our prosthetic components and easy access for care. Proper placement of the implant platform is essential. Too deep, and we're going to have a tunnel effect, which will lead to poor oral hygiene and increased risk of disease. Next step is our prosto treatment planning. Here, we're going to ensure that the prosthesis design is going to allow for oral hygiene access and professional monitoring. So we want to ensure that the contour of our implant prosthesis is going to have an optimal emergence angle and shoulder. That's going to help us with plaque control and prevent implant disease. Now we can see an image here. It's not my own. This is from Hygiene Edge on YouTube of and it was actually very difficult for me to find a good video on probing around the implant. And this is quite interesting. There was actually a fight about this a few years ago about whether we should be actually probing around implants or not. And at the end of the day, we can say that probing won, but there's a lot to it. And if you go and look at some of the lectures available, there's some academics who give an entire 1-hour lecture on just how to probe around. When do you probe around? What instruments should I use? So this simple step, if we take this part away from this lecture, I think it's going to benefit our clinical practice. And I get it. Look, we're seeing patients, we don't have time to probe. Now we see implants, we start getting worried. We don't necessarily have plastic instruments in our practice. We jump to our metal probe, then we remember that, okay, oops, maybe I shouldn't use a metal probe around the area. So when should I probe? How should I probe? Even amongst our clinicians, yet the faculty, I just realized how people have different ideas of this very, you think, one of the first things we learn in dentistry. But the consensus is we should try to wait 6 months after implant restoration before beginning to probe around that area. But we need to probe. Probing is we need to do this. We need to detect peri-implant mucositis and peri-implantitis earlier. But what we've also got to remember is that our implants are going to lack a periodontal ligament. So that's why we've got to control our periodontal forces, hence the need for precision. And you get those fancy perio probes, those white ones, and it's got like a stop there, so you can't over probe in that area, and you have more of a reproducible probing type of things. I've bought mine. I bought mine online, and it is quite useful. So plastic probes, metal probes, you see a lot of videos, they're using metal probes, but we want to prefer to use plastic probes. And there's a lot of debate, does it really matter? But what we do know is that we could lead to scratching the surface, especially on exposed threads or abutments in those areas. So we want to try to keep to plastic instruments. Plastic probes tend to be gentler, but the problem with them is if you use them, they're flexible, they snap off sometimes. So that might actually affect the studies have shown, classic studies by Mombelli, that it might affect our accuracy when we go into deeper periodontal pockets. Now, how do I probe? Some use a light force of, they say 0.15 to 0.25 newtons, but I don't know. None of us are measuring that. None of us know how much of force we're actually applying it to that area, but we're going to try to be as gentle as possible, avoid damaging that peri-implant tissue. We're going to place a probe. So here, people say that angle the probe and then go into, and then parallel it. We're going to follow the long axis of the implant and insert it very gently into the peri-implant sulcus. And then just remember, you don't freak out, because the pockets are going to be much deeper, because we know there's a difference in the tissue attachment now. So even a pocket of 4, 5 in some cases, they're going to be completely normal in your peri-implant cases. So if you see these type of pockets, don't always be alarmed. Remember that there is a difference. Now, moving the probe around different teeth, we're going to, around multiple implants. You saw how they moved it around that area. Some people say that you can go up and down like bobbing, but I like to feel that entire area there to see if there's any differences in the bony margin. An interesting tip that I picked up was, do we need to wipe the probe between different sites? Because, well, it makes sense to me. We're going and probing in maybe an infected site, and we're using the same probe, and then are we translocating that bacteria to a different site? I'm not sure, maybe. I think we need more studies to show contamination in terms of this is actually a thing. So the recommendations recommend that you're going to have peri-implant probing for our bleeding on probing scores, depth, and the mucosal margin changes. We're going to conduct a baseline probing within 3 months of prostate delivery. Okay, so that's a bit different from, I would generally do 6, but we'll go according to the recommendations here, which is 3. We use a 0.5 millimeter diameter to probe, 6-site probing. We're going to look at the keratinized tissue as well while we're there, and obtain our baseline intraoral radiographs and follow-up radiographs as well, if our probing depth increases with our bleeding on probing and suppuration. So let's look at the recommendations for peri-implant health. Now, the first key aspect in terms of peri-implant health is glycemic control. And for patients with diabetes, we know that it's well established that poor glycemic control may contribute to increasing the risk of peri-implant complications. So you want to take not only a finger prick test, which is generally a random glucose test, which a lot of us have in our clinics, but we can also do finger prick point of care HbA1c tests, or we can send it to a reference lab to get those values as well. So this is important in terms of peri-implant health, especially if it's a diabetic patient. So That's part of the recommendations. Let's see the next recommendation would be supportive periodontal care. So this logically is important. So patients need to come in to prevent the progression of towards peri-implant mucositis. We're going to do regular monitoring and professional cleaning for patient. Cigarettes, smoking cessation. So yeah, there's various things we could use. And here they show that going cold turkey compared to other effects actually just support and medication does help with some patients. And there were medications that we were giving patients previously for smoking cessation. Some of them have been taken off the market recently. But here, combined specialist support and having prescription medication seems to be more effective than any other way of stopping a patient to smoke. So just telling your patient, look, you can smoke, you'll stop smoking, go cold turkey, or use a nicotine replacement patch, or use e-cigarettes. The most successful approach is a multidisciplinary, which will include support and medication for your patient. Also, what's important is things we've spoken about. So the assessment and augmentation of the peri-implant soft tissue. So this is more beneficial to do it pre-implant placement. We're going to look at the width. We're going to do all of our measurements, width around the implants, which is going to influence and improve our stability, aesthetics, and resistance to infection as well, and improve the patient's oral hygiene. Things that have not, the recommendations I've said are question marks. So here we can look at bruxism and parafunctional habits. So with bruxism, we know that this contributes to tooth-wear fractures and issues and other parafunctional habits. You can see a picture here of nail biting as well. But there's currently limited evidence directly linking bruxism to peri-implant disease progression or any other habits for that matter. Then the next recommendation is when it comes to the use of adjunctive antimicrobial agents. So this is in the context of supportive peri-implant care. So patients with recurrent peri-implantitis, the professional application of local peri-implant mucositis is generally not recommended. The evidence supporting the effectiveness is inconsistent. So the studies have shown that the primary focus should be emphasized on mechanical biofilm disruption and professional maintenance care. We tend to be over-reliant these days on antimicrobial agents, and they are stating here that these agents are not may not provide the additional benefit that some clinicians may expect. So we also have the issues of ongoing antimicrobial resistance with that. For peri-implantitis, so the non-mucositis, non-surgical management of it is typically managed by effective oral hygiene measures. Studies have shown that with consistent treatment, we're going to have about a 1 millimeter reduction in pocket depth and between a 15 to 40% reduction in our bleeding on probing scores. This shows us our body's ability to actually reduce inflammation when the biofilm control is optimized. So our primary treatment focus here is mechanical therapies. We can use various forms, curettes, titanium brushes, ultrasonic devices, air abrasions, and they mention even chemical agents, photodynamic. We said that some of these we've got to just watch out for. So we've got to take these with a pinch of salt and look at our EFP guidelines as well. Now for peri-implantitis, and if you want to have a full understanding of these EFP guidelines, I would recommend that you go to the Scarano summary of it. They've got very nice tables which they've summarized the various treatment options. So here we have assessment of, we're going to assess the non-surgical peri-implantitis treatment outcomes, monitoring the inflammation, suppuration, and probing depths. The EFP recommends implant level endpoints. We want to make our residual probing depth less than 5 millimeters, no bleeding on probing at more than 1 point, and no suppuration. If we don't achieve these, we're going to need additional treatment. So we're going to reevaluate outcomes after 3 months, which we mentioned before, with prudent and frequent monitoring at each phase. They recommend supra and submarginal instrumentation, but they discourage the use of lasers, air polishing, all of those things, antimicrobial photos. So we can see from the previous recommendation, things have changed. So we've got to ensure that we use the latest EFT guidelines, and we discourage from using some of these other tools. These are based on concerns about patient health, potential systemic antibiotic impact on public health, and insufficient evidence. Now, with peri-implant mucositis, the treatment of it, they've recommended that effective oral hygiene practices are important. We're going to use ultrasonic devices with plastic-coated tips, air polishing devices, etc. And then at the first round of meeting the desired endpoints, such as reduced pocket depths or bleeding on probing, if we don't achieve that, we're going to repeat it again within 3 months. And it's important to adjust the treatment without damaging the implants. While mechanical implant removal while mechanical plaque removal is critical, our adjunct therapy as well, it should be considered in certain cases. Additionally, the use of oral irrigation devices. So we're going to use adjunct therapy, oral irrigation devices, and we're going to modify any problematic crowns, any prosthesis. So this is going to assist us with our treatment of peri-implant mucositis. Here again, the use of any systemic antibiotics or even topical antibiotics is not generally recommended for the treatment of peri-implant mucositis. Lasers, air polishing, no. Okay, so my patient, let's go back to that first patient who came in who was edentulous and required implants. So let's see how I managed the patient. So we can see hard and soft tissue deficiencies. A free gingival graft was done to address the patient's soft tissue deficiency. So we did this all pre-implant placement. Then the implants went in, and this is implant placement. And we can see an issue here. So while I was able to achieve a very nice keratinized tissue with around the implant in quadrant 4, if we look at quadrant 3, there's an area there where we didn't really get a great keratinized mucosal width and height. So in that area, I actually experienced continuous bleeding in that area. So it is a case of peri-implant hard and soft tissue deficiencies, which have then led on to a peri-implant mucositis because some of those earlier factors have not been addressed. So I really want to address it. We know the next step is down the line, we're going to have peri-implantitis. This patient is a little bit hesitant at this stage to undergo another surgical procedure. Now, surgical treatment, I think we're going to try to wrap up. I know we were supposed to end at 8, but we're going to eat into some of our Q&A time. So just because I think we're getting to some of the important points of this lecture. And when do we actually consider surgery? So can I manage this patient on my own? Do I need to send this patient off to a specialist? So surgical intervention is recommended when the non-surgical therapy fails to meet certain key points, such as reducing the pocket depth to less than 5 millimeters and ensuring the minimal bleeding on probing is less than or equal to 1 millimeter. So if we don't achieve this, then the next step is going to be surgical procedures. So we're looking at the period pocket depths and the bleeding on probing spots. Then the reconstructive approach, especially when we have an intraosseous defect that are less than or equal to 3 millimeters in depth. In this scenario, we're going to need to do a bone graft, sometimes with or without a barrier membrane to help restore that area. Sometimes it's important to note that there's uncertainty as to whether at this stage submerged healing or transmucosal healing is going to be better. Now, access flap surgery or resective procedures are both recommended, depending on the case specifics. So the goal of these surgeries, we want to reduce or eliminate the peri-implant pockets. And then when it comes to addressing the osseous defects, we can choose between an access flap alone or just pair it with reconstructive procedures as well. But no single technique. A lot of people ask which is the most effective technique, which is the most superior technique. There's no single technique which has been proven to be superior to the others. So it's tailor-made according to your specific defect and the patient condition. Now, what are the recommendations in terms of implant surface decontaminations? So they recommend air polishing. Another alternative here would be for erbium lasers, which have been used for surface decontamination. So what they've said here is that the long-term efficacy, as we mentioned before, it remains mixed. Titanium brushes, though, that's emerging as another tool to physically clean off the surface. However, they say that we should be cautious about implantoplasty. That's when we smoothen down the area, because there's currently insufficient evidence to fully recommend this at the time. And the same goes for laser. When we turn to chemical contamination, here they say they've explored both chlorhexidine and photodynamic therapy, and there's not enough evidence to support the use of these two. Now, adjunctive antibiotics, again, not enough evidence. And when it comes to the implant supported prosthesis adjustments, they recommend that adjustments need to be made to, especially to avoid hindering oral hygiene. And in many cases, removing the prosthesis during surgery is going to improve our access to the implant and enhance our healing outcomes. What happened to our first patient? Multiple failing implants. This was seen recently. Our patient went to the implant fairy, the rock. It's gone to the bin. Unfortunately, there are some cases where maybe we could have approached the case differently. Maybe there's a lot of patient-related factors that have also contributed to it. This patient was seen pre-COVID, and he kind of got lost during the system. So it is a patient we're going to look at again, keeping the new recommendations in consideration, because there were multiple different types of peri-implant issues occurring there. And thank you to Dr. Rajkumar for supplying me with the information for that patient. Our other patient, peri-implant hard and soft tissue deficiencies. So we saw this patient earlier with the malpositioned implants. We can see soft tissue issues. Still bone issues that might have contributed to the implant positioning. This patient was treated. I removed those healing abutments. We replaced it. We actually see very good bone around in the periapical there. He's had his restorations replaced. This was when he was in his temps. And this case, we managed to solve it by just addressing the prosthodontic issues. So we can manage these soft and tissue, hard tissue defects sometimes by simple solutions. This is another case, so the last case we're going to show. It's a case of peri-implantitis, and we see we've got pockets, probing pockets. We've got bleeding on probing scores. We've got bone loss around the implants, and you can see the cause of it. The cause of it are the crowns. So this patient, I removed the crowns for her. We addressed problems with the soft tissue. So if you look at this picture there, you can see lack of keratinized tissue, which is also contributing to the issue. So we've then done a free gingival graft in that area. This was multiple procedures were done for this patient in a staged approach. We did bone grafting as well. And I do apologize for the quality of the second periapical, but you can see it's not a perfect result, but it's a result. Okay, those marks have moved there, the markers have moved, so it does look different, but you can see in the picture one, a much more pronounced defect, and in picture two there, we do have some success with that patient. So just in summary, peri-implantitis, it poses a silent threat to our implants. And it's important for us to actually diagnose these conditions and monitor it. So find out, differentiate, is this peri-implant mucositis? Is it a reversible condition? Is it peri-implantitis? Is it irreversible? then we need to refer to our evidence-based guidelines, like these S3 level recommendations. These were released last year. And I actually wasn't too familiar with it initially before this lecture. I was still using the SIS protocol. But going through it, it's good to see that now we can back our interventions up. Addressing implant issues, you don't feel like a snake oil salesman anymore. A lot of times we've been peddled these various interventions, but now I've got an evidence-based solution for addressing some of these issues. But even all of that being said and done, we've gone through some of the more complicated things and tools you can use. The primary thing is prevention and proper patient pre-op assessment, and trying to address the problem earlier in the intervention. So if we look at it, trying to address the issues during the primordial phase or the primary phase. And with that, I would like to thank you for your attention for this lecture. And we do have some time still for some questions. I'm just going to see Dr. Standa. Am I still sharing? Am I stop sharing now?
Thank you, Dr. Vedan. Thank you for the very informed.
Sorry,
Yes.
I just want to see here. Am I still sharing my screen? Am I out now?
Sharing. Thank you, Dr. Vedan.
Okay, cool. All right. No, that's fine.
And thank you for providing us with this very well-prepared, informative lecture. No,
Yes, I can hear you.
Thank you. All right, Dr. Vedan, some of our participants, we received some questions. So we received some questions from the participants, and I would like to ask you, we have from an anonymous attendee. First question is, at what point do I, as a general dentist, refer a patient with peri-implant disease to a specialist for further management?
Okay, so thank you. That's a very good question. So we've gone through some of the recommendations in the EFP in terms of the bleeding on probing, and more importantly, the probing periodontal values there. So you've got to first diagnose your patient, determine, is this a peri-implantitis case? Is it a periodontitis case? And then you're going to have to look at your skill level and see whether surgical intervention is something within your scope, or whether you'd rather send out to a dental specialist then. So when it comes to non-responding peri-implantitis cases, after our first initial and looking at the pocket depths, of course, and when it's not responding, I would then look at referring the patient out to a specialist.
Okay. Then, second question that we received, what role does implant surface design and/or implant position play in the development or prevention of peri-implantitis?
Okay, thank you. This is a really good question. So the design of our implant is going to play quite a crucial role, an important role in the osseointegration of the implant. And then its risk of developing peri-implant diseases. So when we have a very, very rough implant surface, we're going to promote better healing in the patient. But then on the contrary, studies have shown that this might also increase the risk of biofilm accumulation. So this can lead to peri-implantitis if we don't adequately maintain that area. Also, other more recent research, it shows that minimally treated or minimally rough surfaces may offer this balance then by encouraging osseointegration and then also reducing our risk of peri-implant infection. So we also need to have like proper maintenance protocols as well. So regardless of whatever surface design we choose, and there's all these fancy surface modifications and stuff, the mainstay for us at this stage, we need to understand that proper maintenance protocols is important. Just going back to that first question about how do I, as a dentist, when do I send the patient? So if you take a simple periapical, and if you see this bone loss evident on the radiograph, and you've seen this patient for multiple visits, and there's a progression of the peri-implant disease, and you know that surgical intervention is required, and that's when my alarm bells are going to start ringing, and I need to refer this patient. Even with the complex cases like the ones we saw, like the one I presented, with these aesthetic concerns, there's issues with the peri-implant mucosa, there's quite a lot of hard soft tissue deficiencies. These are cases too I'd rather refer out.
Okay. And then another question, is there, in your opinion of research, is there any advantage of one connection type over another in peri-implantitis occurrence or prognosis?
Sorry, can you repeat the question?
The attendee asked, in your
Yes.
opinion of research, is there any advantage of one connection type over another in peri-implantitis occurrence or prognosis?
Okay, so good. Yeah, this goes towards the same thing in terms of implant designs, prosthetic interfaces. So we know that the connection actually plays a very important role in the progression and management of peri-implantitis. So if we look at the implant abutment interface, if there's any micrographs in the area, if we have misfits in the implant abutment junction, this to me, it makes logical sense that there's going to be then bacterial infiltration into that area. So there's going to be biofilm and then eventually peri-implant inflammation. Now, this is the big debated topic, and here in our faculty, external hex implants are like a swear word there. We try to keep away from it, and I know a lot of our other colleagues, especially MaxFac colleagues, they tend to still to use external hex. Well, studies have shown that external hex implants are more prone to micro movements and microgaps. We're not saying that don't use it at all. There's an indication for them, by and large, but we've also got to bear in mind this increasing risk of bacterial leakage with them. Now, the internal connections, so those are like the conical connections and Moss taper connections, which we use. I'm tending to favor conical connections these days, but that ensures that we have a better fit in that area. So we have less micro movement and less bacterial colonization there. So it gives me more protection against peri-implantitis. Then there's other things. We know what platform switching is. So this is when you have an implant and your implant abutment is much smaller in diameter than the implant platform. So this is where the logical thing about this, or what they thought it does, it moves the microgap away from the bone. So you're going to help preserve the peri-implant bone there. And there's enough studies to show us, and this is something we're practicing more and more, that platform switching helps reduce our crystal bone loss in that area and decreases the risk of peri-implantitis. But like important things that we need to do that I fail to do all the time. Sometimes I'm struggling. We don't have time to just take a post-op X-ray there just to check the seating of things. And it's something I'm trying to do more and more often. Just a simple thing like that, because if we're going to have a tight connection in that area, we're going to ensure that there's less micro leakage and bacterial invasion. So make it a point of taking enough X-rays and screw issues. So I think sometimes I tend to use the same screw, and if I am having screw loosening, I will utilize the same one. But I've seen now that if you're having screw loosening, if you're having these issues, people chuck it away and buy a new screw for that. So, that's also something we've got to consider. All of these are different connection things that we need to consider for when we place implants. Unfortunately, there's not a one-size-fits-all solution to it, and we've got to look at the situation and the specific indication for our patient to, so we can decide which connection to use. But I'm getting learning more and more about the importance of choosing the right interface. But it's an excellent question. It's an excellent question. Thank you.
Okay, we've got also from anonymous attendee said they attended another lecture where floss that was stuck around the implant was the result of the implant failing. So what is the best way to clean for the patient around the implant? Is it interdental brushes? Is it a water pick? What would you recommend?
Right. So interdental care, we know there's many things we can recommend to a patient. Physically cleaning out the area. We've got interdental brushes. We've got different flosses. We've got super floss. We've got water picks. We've got water picks with using medicament as well. So there's all of these different things. And we've got to think about what does the literature say is the most effective way what am I going to recommend to my patient? So they actually say the most important thing is a combination of many different modalities. So telling your patient, look, just use the water pick alone is not as effective as telling them, look, use the water pick, but use another mechanical tool as well. So you've got to tailor this to your patient as well. You've got water picks are a solution. Not all patients can afford it. Mechanical cleaning, we've got to make sure that the specific thing we've recommended to our patient is something that they can use. Your patient flossed that area, and then they had peri-implant issues after that. So for me, that completely makes sense. There could have been, so that's a foreign body impaction from the floss piece, and that might have led to plaque buildup. And then that would have led to the whole cascade that we've spoken about, peri-implantitis initially, then bone loss. So that's also highlights the importance of our supportive periodontal therapy for our patient. We're regularly monitoring these patients. We're looking out to see if there's any of these issues. But yeah, it's an excellent question, and things that need more. We need further information about it. But for now, the consensus seems to be a combination. Water flosses are very high on in terms of efficacy at the moment. So I would recommend a water flosser to our patient if we can, but I would also tell them to supplement using water flossers with either interdental brush or floss.
Yeah, and I think it's very right. So what you said, it needs to be tailor-made to each patient's needs. If
So
there's a
what's
patient
your
maybe with
thoughts on this,
post.
Dr. Standards? Yeah, it would be interesting to see how do you approach this in everyday practice?
So again, it needs to be tailor-made to
Yes.
each patient's needs.
Yes.
And if a patient is a high risk with maybe a history of periodontal disease and it's a posterior implant, and there might be dexterity issues at play as well, then most definitely follow that patient, place them on a shorter supportive periodontal therapy program, help them to professionally clean in between so that if there's changes in the peri-implant tissue, we can pick that up early. But yes, I agree. Combination is always better, not just to stick with one single tool like floss alone.
Right.
Floss, interdental brush, water floss. A water floss is an excellent tool, but it needs to be tailor-made to each patient and regular visits depending on their needs.
Right.
Okay.
And any specific mouthwash, rinses, any specific additions to the water floss? Do you tell them to maybe try water floss and add anything to it?
Look, I usually tell them to use water, but depending on, what the patient present with, I will tell the patients to use a mouthwash as well. I still prescribe a chlorhexidine-based mouthwash if there is if there's a history of periodontal disease, or if there's some areas that is flaring up, if there's unstable periodontal pockets, I will place them on a shorter interval as well. Okay. All right.
Thank you. Thank you. It's
Okay.
quite interesting. Thank you.
Then what we have is there's another patient or person that says super floss and water floss. Which one between the two? I think you answered the question.
I would go with water floss. It's been there's recent evidence to show us that it's more effective. Yeah.
Right. And then there was another question that was asked by attendee. What
Yes.
role, at what point do we consider titanium allergy with implant failure or peri-implantitis? And have you ever dealt with this? And would you be able to give some advice with regards to treatment?
Wow, it's a great question. Titanium allergy. I actually had a patient recently who thinks she has a titanium allergy. I know there's a test. I can't remember the name. Do you know of Dr. Standard? There is a test we can do to actually test for titanium allergy. I can't remember the name off my head. But anyway, ELISA test. Yes, that's it. ELISA, like ELISA, but ELISA. So that's a memory lymphocyte type testing. But they can also do like patch testing, I guess, and we can look at clinical symptoms as well. When it comes to these patients now, so it's important if we suspect it is a titanium allergy. I don't know how we're going to suspect it, but then we're going to look at other options. There are these ceramic things. I placed one. I was lucky. It was my first one. I placed it the other day. Those are things we can look at, but we've also got to remember that some of the components of those implants are actually titanium itself. So firstly, the actual incidence of titanium allergy is quite low. You know, patients get titanium stuff placed in all the time. If I see it, I would try to maybe look at non-surgical treatment first, trying to clean out the area. If it really is looking at the symptoms that the patient has, if it's definitely confirmed as titanium, then I'm going to try to remove it and replace it with these zirconia implants. These, they say, we're going to take these things with a pinch of salt, but I have been told it's much more biocompatible. They have very low allergy risks. Whether we can manage it with other things, I don't know. Antihistamine, I don't know if that is an effective way to chronically manage this issue. But maybe like patients with known metal allergies, those are the ones we've got to consider doing these tests for. I'm not sure who offers these sort of testing, but yeah, we can look at it. I think if a patient is confirmed with a titanium allergy and it's causing significant morbidity to warrant removing the entire implant, and we've eliminated all other factors, then we're going to have that implant removed.
Okay, so there's just a question I wanted to also ask.
Yes.
We've now talked about peri-implant disease. We've talked about signs, symptoms, and various techniques of treatment. Early identification and prevention is always best. Say we've recognized, we've diagnosed, we've done all the treatment, but there's still persistent peri-implant disease. At what point do we consider removing an implant?
So we've monitored it, we've tried to treat it. We see there is progressive changes. So if I'm still treating the patient, there is more than 50% bone loss. I tend to use 50%. I'm not sure. I think there might be some evidence to back that up. But if I see more than 50% bone loss on the implant, if I'm seeing quite a lot of morbidity, patients in severe pain, there's pus oozing, it really is we've looked at the CBCT, we see there's malpositioning issues, we see that there's issues that there's no going back from, that no amount of grafting is going to fix. then we're going to have to make the call and have the implant removed. And we know it's difficult. We know sometimes you place in the implant, you've put in the crown, the patient's paid a lot of money. Who's going to cover this? So you've got to make that call sometimes. Looking at these guidelines, we've said, looking at the classification, you've got to understand whether this is a situation that can be salvaged or not.
Okay. Thank you, Dr. Vedan, for tonight's lecture.
We have quite a few questions today. It's interesting.
Yeah.
A lot of things I need to read up onto as well.
No, thank you, Dr. Vedan. I think you've answered. And I hope everyone enjoyed it. It seems like it was a lot of questions because people were interested at the lecture, and it sparked it sparked a discussion. So thank you very much. To our attendees still that is logged on, I would like to remind them next week, Wednesday, directly after the public holiday, there is going to be another SASPIO webinar. This next webinar will be by the University of Pretoria's Dr. Michaela Beetge, who will be presenting on empowering patients and students in periodontics, the 2080 rule and effective patient education. Then I also would like to just remind our SASPIO speaker for our next annual SADA meeting in Durban next year, from the 25th to the 27th of July, will be Professor Lisa Mayfield. She is a world leader in peri-implant disease, management, diagnosis, and she will be our guest speaker, SASPIO speaker for that event. So please diarize now already for next year. We look forward in seeing you again next week. Thank you, Dr. Vedan. Thank you, Sada. Have a lovely evening. Bye-bye.